Anzalone. And I'm not sure if you guys have had a chance to read his bio, but Jono actually is a Creighton alum. He graduated from Creighton with a BA in political science, and then also the University of Nebraska with an MS in economics. He also went to the Harvard School of Public Health and Kennedy School of Government National Preparedness Leadership Initiative. And he has earned the International Association of Emergency Management Certified Emergency Manager credential. So today he's going to be reflecting on Ebola and the response in Liberia. It's a warm welcome.
Thank you very much. I suppose last session, post-lunch, post-keynote speaker, so I'll try to keep it as interactive as possible. A little bit of feedback.
A little bit of feedback.
If I turn it off from now, will it cause any problems if I keep it off?
They won't hear you on the recording. Do you want to try it one more time?
Yeah, maybe I'll just try standing away from.
I think the speaker's right there.
There we go. Does that sound?
This is when we need more.
Yeah, I don't have a volume control on the lapel mic.
You can look.
It's just a on-off switch.
Well, I think...
We have the first session.
Yeah, I think
Does that
it's
work?
okay. Yeah, I think it'll be all right.
This one will be a little bit better than the first session, so
Yeah.
Anybody that's watching the recording, unfortunately won't get to hear the afternoon comedy. So appreciate the introduction. I don't have a medical background, so I found myself amongst people that knew much more about medicine when I went through the Harvard Chan School, in particular the interface that it had with the Kennedy School of Government. By way of background, I grew up in the Red Cross system and have found myself still there. What I'll do this afternoon, I believe, I said I knew how to operate this, but I don't know if we're actually on.
Just a little side guide.
Yeah. Is it actually off?
Oh,
there we go. Perfect. Start off a little bit of introduction. I usually like to start off by really just acknowledging the incredible public health system here in the United States. I was greeted immediately after re-arriving in the United States by a professional public health individual who did my monitoring for 30 days, and she was really life-changing for me. Having read all the negative experiences that nurses and doctors and public health professionals had experienced going to Sierra Leone and Guinea and Liberia, I didn't know what to expect, and I purposefully flew into Dulles International Airport and avoided several other hubs across the United States based off of negative experiences that healthcare professionals had had, and could not have been happier with my welcoming. I live in Sarpy County, so my Sarpy County public health nurse became one of my best friends, and I meet with her still every other month. We have lunch, talk about all things. She just spent lunch with me on Friday talking about Zika virus, which I knew nothing about, but really just an accolade to the developed public health system that we have here in the United States. Like I said, my name's Jono. I go by John, go by other things as well, and really grew up in the Red Cross system here in the Omaha metro area. After I finished graduate school, left for about 10 years and came back, where I currently cover a large territory within the upper Midwestern states all the way down to Kansas, Oklahoma, but still have an international mission with our International Red Cross Red Crescent. But I've been doing this for a long time, really enjoy it. I have a passion, tying it back to what Dr. Anthony was talking about, having a soul and passion for what you do, I think is critical for this type of work in order to avoid burnout and to make sure that your motives are in the right places. And continue to love what I do. I've spent many birthdays and occasions in different parts of the globe. Spent 2 years, nearly 2 years in Central America, in Panama, with International Federation of Red Cross Red Crescent Societies. Kind of detailed there with our Caribbean, South American, and Latin American unit. And have kind of done a crosswalk of both domestic and international relief. Some of the experiences that I found myself in are very life-changing mass casualty events. Spent 2 weeks in Newtown, Connecticut, a day after the shootings there. Was ironically just a couple hours away in New York City, responding to Hurricane Sandy. And because of the type of event that happened in Newtown, Connecticut, mass casualty, non-Stafford Act event where FEMA didn't have jurisdiction, there were some very unique challenges that they called upon the Red Cross to help address. Things that traditional federal resources couldn't because of the nature of the event. And those have really kind of shaped who I am as an individual and led me to this kind of epiphany when I was getting calls in October and November, and our international services unit kept asking, can you go to Liberia? And I thought, you know, I'm personally not scared about going to Liberia. I had friends and family. My partner was certainly concerned just because of the stigma that was attached with medical assignments in that part of the world, given the media attention. And really had to ask myself, is this the right decision to do for my family, for my friends, absent what I knew was the right thing to do, because we were having a hard time not only getting medical professionals to go. I'll talk specifically about my economic security mission, which was less medical, but found myself at the crossroads of having to work with medical practitioners that I hadn't quite seen before in previous deployments. The passion behind why I did it is tied to this little thing that I keep on my desk. I've been carrying it around since 1998. A public health nurse that was on deployment with me for some flooding that had taken place the summer of 1998 in Hamburg, Iowa, just along Interstate 29 in southwest Iowa. I was asking her, she was 70-something, you know, why do you volunteer? You have many choices in how you spend your free time. And she shared with me that when she was a little girl in home economics class in an all-girls school, her home economics teacher wrote in the back of their books a thing that really symbolized who she saw in them as young women, as young girls. And this is what she wrote to me that really helped shape what I did in undergraduate and graduate school, and here I am today, under 40, still doing that line of work. And it's a little bit hard to read, but it says you have to give yourself to life before you really live. It's foolish hoarding love or wealth, those lose who never give. And to me, that was what really made many decisions along my professional career leading up to where I'm at today and kind of staying in this line of work. Obviously, it's an atypical route for an economist to go. My friends work for big banking firms or consulting firms or some of the top 3 consulting firms, and they have really good lives financially. But it was something that was missing from that equation that really stems back to how I was raised and really the type of work that I was doing. So made my decision to go to Liberia a little bit easier, and I'll spend the rest of the time really talking about the mission in Liberia and what that meant in terms of crosswalking what the NGO community does, like the Red Cross and Red Crescent societies, with the professional medical community that was found there responding to the disaster. A little bit about Liberia. For those of you that know anything about Liberia, very war-torn country after 2 decades of civil strife, and per capita income is less than $400 US dollars per year. And a lot of times when I have my iPhone in my pocket, I pull out my iPhone and I think to myself, this is the annual per capita income of individuals that live in that country day in and day out, who have no other option to live in any other country, any other part of Africa. And it really kind of hits home when I look at a device like this and think this is a year's worth of income for an average Liberian. Absolutely stark contrast to what we're used to, right? Population of 4 million, very strong ties to the U.S. If you're familiar with Liberian history, we sent back slaves to Liberia and gave them their land back. And interesting from a very cultural anthropological perspective is those that were repatriated from the U.S. who were once slaves have extreme social stigma, including the President Sirleaf Johnson, who has descendants from the U.S. where they were slaves. And she's, by many in the outside area of Monrovia, the more rural area, isn't considered a Liberian because she's 2 descendants removed from the U.S., even though prior to that, 3 or 4 generations ago, she was actually rooted in native Liberian culture. So fascinating contrast, 20 years of civil war. I'd like to share a couple of pictures. This is one of the buildings, one of the largest buildings in Monrovia, the capital. And you can see little holes or divots in the cement. And first, you know, I'm an American, I'm a Westerner, I assumed that's just atrophy of buildings. That's what normally happens with old buildings. And it was very stark for me to understand that those were actually mortar attacks, gun attacks, and in this particular part of town, it was a strategic location for the Charles Taylor regime, and actually maintaining control of Monrovia. But this was very common. You could not walk down the street or streets without seeing signs of 20 years of civil war. So you add that on top of Ebola, and it really starts to make sense how a country could fall so far behind in maintaining basic health precautionary measures, protective measures to keep such a terrible disease from actually spreading. Kind of a little bit about the mission itself. I say a little bit about the ICRC. So the Red Cross is made up of 3 separate movements. Not to bore you with Red Cross history, but there's what are called national societies, and that's things like the American Red Cross, the Canadian Red Cross, the Liberian Red Cross, the Danish Red Cross. There's 186 national Red Cross or Red Crescent societies all across the globe. Okay? There's a second component, which is what's called the International Federation of Red Cross and Red Crescent Societies. Their mandate is to care for the alleviation of human suffering through non-disaster, specifically international armed conflict zones. So traditionally when there's a hurricane or a tsunami or an earthquake, the IFRC has the lead in organizing all the international Red Cross, Red Crescent components. I use Haiti as an example. Haiti is not an area of international armed conflict. There's an earthquake. Every single Red Cross national society with money, like the Danish and the Germans and the British and the US, want to deploy resources. They want to help. They want to send money, manpower, material, and that can be a huge coordinating effort because the Haitian Red Cross doesn't have a lot of resources and they can't always adjudicate all of those moving parts from across the globe. So the IFRC has the lead coordinating role under the Geneva Conventions in mobilizing, coordinating those resources. Third component, outside of the national societies and the IFRC, is what's called the ICRC. Anybody familiar with ICRC? A little nuanced language, but they specifically have a mandate under the 1983 and 84 Geneva Conventions to intercede in areas of international armed conflict. It is the most ratified national treaty on the books, even today, with countries across the globe that you would never expect having signed the first Geneva Conventions. What they do is maintain human dignity, uphold human dignity in the worst parts of the world where there is international armed conflict. The reason I mention that, because of the history of Liberia, Liberia was one of our 79 permanent missions where the ICRC had the lead role because of the armed conflict that had been there for nearly 20 years prior to President Cyril Johnson winning the elections in 2007, 2008. So we had assets on the ground. We worked closely with the Liberian Red Cross, and all of a sudden, a year and a half prior to Ebola, we were scaling down our mission because there was relative peace in the country. And we found ourselves asking the question, what is our role as an international Red Cross humanitarian organization in responding to this terrible virus that was obviously causing many deaths and suffering throughout the Western African countries and a lot of scares in other parts of the world. So our response was largely based off of the Geneva Conventions, strict language around upholding human dignity, alleviating human suffering. And fortunately, throughout the globe, the ICRC has trained medical professionals, surgeons, anesthesiologists, public health nurses, all sorts of medical entourage to be able to surge from across the globe in order to add some value to this type of response. So specifically, within the ICRC, we have a specific mandate under the Geneva Conventions to uphold human dignity in detention facilities, kind of a very niche field. And when somebody is no longer considered an armed combatant, meaning they set down their arm, under the Geneva Conventions, the other side of the conflict is not supposed to harm them. Oversimplifying a bit. But armies, traditionally dating back to the Civil War, they put down their arm, they are afforded certain rights under the Geneva Conventions. All signatories of the Geneva Conventions agreed to this. So based off of our mission in upholding human dignity in detention facilities in Liberia, we had a very specific role in keeping Ebola out of the prison system. The number of prisoners that cycle through the Liberian prison system is outrageous compared to the infrastructure of the facilities. This is a picture of the largest prison in Monrovia that we had a large presence in. And our role was to train detention officers, to train officials within the prison system, and most importantly, to socialize amongst the prisoners safe handling, safe hygiene practices. There was a no-touch policy in place which prevented the disease from actually spreading. should have prevented the disease from spreading. And throughout the entire duration of Ebola in Liberia, there wasn't one confirmed case in the prison system, largely because we made sure that there was safe and secure water being piped into the prison. The handling of prisoners in terms of fever monitoring, this was done 3 times a day. Real basic practices, but for an NGO, we have a very unique role in specializing in detention facilities. It's not a very appealing activity outside of the Red Cross, because most donors that fund NGOs want to help babies, they want to help mothers, they want to help other vulnerable populations. But under the Geneva Conventions, we have this very specific mandate to make sure that everybody has human dignity upheld. Everybody is ensured basic rights under the Geneva Conventions. We sent in, this is a colleague from the Egyptian Red Cross, Red Crescent, who's a water engineer and was making sure that water was available in order to stop the transmission of the disease, which is really a basic combination of water and chlorine, kills the disease, kills the virus, and making sure that they had access to that chlorine and access to that water was absolutely significant. The other piece that our medical staff focused on was nutritional requirements for both patients of Ebola and those that survived Ebola. There wasn't a lot of literature or research that had been done around nutritional contents that were required for people that actually had the virus. And as a result, there was lots of consternation about how do you feed people that have Ebola. And I'm not a nutritionist, but I heard many conversations about the ratio of proteins to starches and all sorts of other things, like the amount of calories that an Ebola patient would receive pre, during, and post. So fascinating discussions. We actually had a memorandum of understanding with the U.S. government, Department of Defense, with one of their Ebola treatment units, and we were the primary provider of nutritional contents within that unit, largely because we had special nutritionists and subject matter experts that understood the nutritional values that we thought were the best known solutions for patients. The prevention activities were kind of the squishy space. We saw what the World Health Organization was doing. Anybody familiar with how WHO works, working closely with the Ministry of Health? A lot of the funding that was coming into the country was getting stuck. I call it the classic titration or funnel problem. You get millions of dollars pouring into a country, all going through the Ministry of Health. Exaggerating a bit when I say all going through the Ministry of Health. A good portion of it going through the Ministry of Health, and they don't have the ability to program hundreds of millions of dollars to build out infrastructure and programs fast enough. So we saw a couple of critical gaps within the ICRC and Red Cross movement. One was on bio-waste containment and destruction. A lot of the fluids that were coming off of patients that were being treated in Ebola treatment units, nobody knew what to do with. They didn't have the proper equipment. They didn't have the proper facilities to stow trash. I know that I was shocked when I saw the only public hospital in Monrovia and the level of waste that had ensued because there was no other place to put it. So this is just outside the general public hospital. So the ICRC said, what can we do? What space can we fill? Not wanting to duplicate what Ministry of Health or other NGOs were doing. So a large part of our mission was in bio-waste containment. We actually procured and shipped in via port 2 huge incinerators. One was used to dispose of waste within the Ebola treatment units, as well as one crematory that was used eventually to process the deceased. And I'll talk a little bit more about that mission because it posed significant socio-anthropological conditions that the people of Liberia weren't used to. We also had water and sanitation engineers. This is a colleague of mine from the Danish Red Cross who trained local Liberians. By the way, 100% volunteer, amazing in my mind, how to properly put on PPE to take it off, how to properly use the incinerator, because it was something in the country, there was not one incinerator in the entire country in order to process the waste. So it was a new thing. So 90-degree temperatures, PPE in front of flames. And there was not a day that any one of those gentlemen would get out of their suits 3 or 4 times that they wouldn't have sweat up to their ankles because of the heat that they were taking part in, and uncompensated volunteers. I mean, absolutely heroes in my mind. You can see some of the equipment that we actually brought in from various parts of Western Europe under emergency procurement. I won't talk about the diplomacy mission, but part of what enables us as an NGO to do the work that we do in war-torn countries and countries that were once war-torn is through diplomatic action. And several of the other panels that I listened in on, that policy level work is extremely critical for us to gain access. I mean, we do prison detention facility visits in nearly every part of the globe that you would never imagine, because we are impartial and we are neutral in our approach, which means that the government trusts us in being true to our mission. We're not taking sides, we're not passing judgment, as well as opposition forces. We do work in Colombia, we do work in the Middle East, and we talk to people that otherwise other individuals aren't talking to, because we want to maintain our neutrality and our impartiality. And most importantly, we teach about international humanitarian law that hopefully over a course of time, even opposition forces will understand that everybody has a right to basic human dignity. Everybody has a right to understand what it means to be a non-armed combatant. This is the Director General for the Liberian Red Cross, just an absolutely phenomenal soul who helped us mobilize the mission using community-based resources. You notice here, it's not a bunch of expats that are going around and doing social education. It is local volunteers, it's local Liberians who understood the communities, that were trusted in the communities, that were from the communities. And a large part of that enabled us, in my mind, to be a little bit different than some of the other responses in Guinea and Sierra Leone. We didn't have violent attacks against our humanitarian forces. And a couple of my colleagues that we were dialoguing with when I was there shared with me just the assaults that they were undertaking in communities because it was perceived that expats or foreigners were bringing the disease in with them. There were some conspiracy theories in communities just because of the cultural differences. And this was our enabling force to actually get the message out there, to gain credibility in communities. And what I eventually believe was the winning formula for community mobilization. These are some of the statistics. I won't bore you with all of them because you'll have access to this presentation and all the materials and data points. One of the most critical missions that we undertook was the actual safe and dignified burials of individuals that had perished. It was a very sensitive mission. We found that NGOs, the Ministry of Health, did not have the capacity to collect bodies, to process bodies, and to eventually dispose of the bodies in a safe and dignified manner. And I live with a medical anthropologist, and a lot of what I learned on how we could best approach this, we had good social scientists on staff, was understanding why the disease was being transmitted. So if you hug your loved one when they pass, and that has been a cultural tradition of yours for 100 years, a Westerner coming in and delivering the message, stop doing that, doesn't work. So we recognized that we had a steep learning curve, we had a steep challenge ahead of us, but the local volunteers that help us process over 3,500 lost lives were uncompensated. They were volunteers from the community who saw this work as being critical to stopping Ebola within their country. This is the social mobilization that enabled that. Millions of tracing contacts where we were able to trace back any hot cases once somebody was identified as actually carrying the virus. And a large part of that was adopting good mass casualty policy and programming. This is from our ICRC head surgeon who said, we're trying to do the most good for the most number of people with very limited resources. Now, granted, lots of money started to come in eventually, but it was a slow start. You guys all know the story in terms of the international community's reaction. And that was really about trying to best prioritize limited resources in a way that made the most sense. This is just a little map of Liberia. The majority of the concentration was found here in Montserrat. Interestingly enough, the way that they were collecting statistics, vital statistics, a little bit skewed because somebody could be from Lofa or from Nimba, along the bordering countries to the north. And if they came into Montserrat or into Monrovia, the capital, they would unfortunately show up as a tick or a statistic in Montserrat. So we knew that there were cases in the outlying counties that just weren't being captured. There was also a terrible social stigma attached with the disease. Terrible social stigma. Loved ones were dropping off their dead or they're sick, not wanting to affiliate with those individuals because of the social stigma attached, where nearly 70 to 80% of households reported housing discrimination or other forms of discrimination from knowing somebody that had Ebola, losing jobs, and I'll share those data points in just a moment. So it posed a significant challenge because people would drive all the way from Nimba, hours and hours and hours, and drop off their loved ones, and then they'd be nowhere to be found. Not because they didn't care, but because of the social consequences that were attached with having the disease. Just a little bit about the sampling that we did, working with the WHO and the Ministry of Health to manage the social mobilization, case management. I will say from a psychosocial perspective, that's a mouthful, that there was significantly less attention to the impact on emotional and spiritual care. The Carter Center was one of the best organizations on the ground that was really focusing on not only the psychosocial needs of survivors, but their family members. Because so much of the money and the programming was focused on the medical response and not necessarily the psychosocial response. It was significantly under-resourced when I left early February, and I argue today that it's still significantly under-resourced, causing lots of secondary and tertiary problems within the community. Attached to that, I often share a story that I was there for just over 30 days. I didn't see one tear from a survivor, from a family member, from our local staff, despite many of them having lost 5, 6 people within their immediate household. And it took me a while to understand why. And I, would often have conversations with our local staff around, hey, how do you feel? And one of the most poignant conversations I had was one of our local economic security delegates, and he said, after nearly 20 years of brutal war in the country, it becomes hard to react to something like Ebola. Just one more thing to bring us down. And to me, it really hit home in terms of how people respond to various traumatic events and something like this. But I was really shocked. I mean, I still look back and can't tell you how impressed I am with the international response, but also the impact emotionally that it has on people after 20 years of conflict. The non-medical side was extremely important. Obviously, I mentioned some of the logistics lift and us mobilizing water and sanitation equipment, incinerators, and other supplies, and huge coordination with the United Nations community in order to make sure that we had a coordinated response. I'll focus a little bit of the remainder of the time on our economic security program and tie that into the medical response itself. I mentioned social mobilization. I'm not going to cover case management. If you're interested in the number of Ebola treatment units, we have good data points on the number of actual units that stood up. This was extremely challenging. One of our primary concerns is that, similar to other discussions that I've heard throughout the conference, there were a lot of people that wanted to come to the country and do good, but didn't have the resources. They had the expertise, but they didn't have the resources. And I saw a similar reaction when I was in Haiti, post-earthquake. I was detailed to USAID, and I saw countless number of medical professionals get on planes and fly to the Dominican Republic, trek across the Dominican Republic to get to Haiti, and realize we have no material, we have no host site, and they found themselves at the foot of the U.S. Embassy concerned because they have no food, they have no clothing, and they were complaining about not having medical supplies. Now, we all know that if they would have asked, should I go, the answer would have probably been different. So part of me is impressed with their compassion and their soul work, wanting to be found where it's most needed. But part of the concern with the number of Ebola treatment units is we had some NGOs that were well established in Liberia that knew the constraints that they would be found on the ground, and we had some that just deployed without a plan. And that's not to be hypercritical, but that posed significant consequences that I'll talk about in just a moment. This is some of the client tracing data that I won't get into a whole lot of detail with. The actual epidemiological perspective was quite fascinating because my programming was strictly economic security, and I'll talk about what that is. It was largely contingent upon good data points around how the disease was progressing throughout the course of the time that we were on the ground, as well as body management. I'll talk about that in just a moment. A lot of good data points that you guys can read in there afterwards. Tracing and monitoring. I mentioned that the access to healthcare services was largely supported through our ICRC mission, but we also had a very unique niche in maintaining other access for patients, such as the maternity ward being reopened. Everybody was focusing on the Ebola response, and we had, fortunately, a good chief physician that said, look, we have to kind of pay attention to the other things that are happening in the country when people present with other non-Ebola cases. So certainly one of our mandates was to reopen the maternity ward because all the other resources were being diverted. One of the sad outcomes of how impactful Ebola was on the medical community is the medical school closed because of a loss of physicians in Monrovia. Many of them perished. But we were fortunate in that the remaining staff, because the medical school were closed, were detailed to our mission to help inform decisions around non-Ebola cases and non-Ebola health-related issues that we had to keep an eye on. So this is just a little bit of information on the Redemption Hospital, some of the stats around our Ebola treatment units. Remainder of the time I'll focus on economic security. So I'm an economist. People often don't think that there is a huge economist role in public health emergencies, but one of our concerns, particularly in West Africa, was maintaining economic livelihoods that would afford people not only human dignity, but to avoid conflict. We know that conflict spikes during both natural disasters and public health emergencies when there's not economic stability, when people don't have jobs and food, crime goes up, rape and abuse goes up. These are well-documented phenomena that happen after such events. So the ICRC mission, especially tied to its history in Liberia, found itself asking the question, how can we stabilize economic livelihoods in a way that is meaningful, but most importantly, that is fast? The international aid community often does get stuck in that funnel, and it sits at the ministry level for a while. And it's not to bypass the ministry, it's simply to enable more humanitarian intervention in a more efficient fashion. So that's what we focused on with the economic security mission. And that was made up of several different components. We partnered with the government of Liberia to better understand what they were planning on doing with other NGOs, Mercy Corps, Medical Doctors Without Borders, and other NGO communities, including African Development Bank, and asked the question, how can we get cash into the hands of people in the most effective, efficient way? And also verify that this was doing so responsibly. The reality check for us is that when people were checking into Ebola treatment units, you saw the number of Ebola treatment units that were out there being run by different organizations. For triage documentation, this is typically what it would look like, is that people would have either no identification because their family members were dropping them at the curb and bodies were piling up, or they would have limited documentation that would eventually be destroyed because it was considered contaminated. And by the way, if we knew where the families lived, once they were a confirmed case, we would have to, unfortunately, destroy all the household goods. So everything inside of it was considered contaminated. And as a result, you now have thousands of people without identification. The average wait, when I left at the end of last year, was about a 6-month wait with the Department of Vital Statistics in Monrovia to be reissued a birth certificate, which was optimistic at best. And so you had people that had no identities. So accessing aid programs from the NGO community, from the Ministry of Health, was largely based off of tracing, person-to-person verification using next of kin or family members. And it may not seem like a huge medical problem, but it is a huge economic recovery problem. When people don't have access to livelihood, they don't have access to finances, they can't go get another SIM card from the telephone company because they don't have an ID. There are all these consequences that you think through that are directly tied to triage documentation. And I cannot speak more highly about what Doctors Without Borders did. They have systems in place, they have documentation in place, they have tracing procedures in place to be able to ensure that we find the next of kin or a family member, even if they don't want to be found, to be able to identify that patient X truly is patient X, which opens up a plethora of recovery resources in the international aid community within the government of Liberia. So deliberate processes, I think, were key, not to critique any single ETU, but there were other ETUs sponsored by other governments that came in that were strictly concerned with patient survival. And I don't want to dismiss that. That was their objective, but the consequence management of that was severe. for families being able to recover if they survived, or for their family members that were eventually traced. So our program focused on 3 different subsets. One is people who were cured of Ebola, the few that did, families of the deceased from the community, and then actually families of deceased in 2 distinct Ebola treatment units. LWA is an organization found in a particular part of Monrovia, and they were named LWA 2 and LWA 3, these particular Ebola treatment units that were run by Doctors Without Borders. We had to be very deliberate in which ETUs we chose because we had to go back to the donor community, unfortunately, and say, here's how your donated dollar is being spent, which seems just ludicrous when you're trying to fight a life-threatening disease. But the donors expect accountability and metrics. We heard that in a couple of the keynote speakers, right? When you're a grant-funded organization or you're using grant-funded dollars. So we stood up a system that made the most sense based off of where we felt we could do the most good for the most many of people, going back to what our surgeon recommended that we do. And here's what the program looked like. So remember, average economic GDP is about $400 to $500 per year. So we chose to do 3 entrenchments of cash, $100, $60, and $40, over a 3-month period. And any guesses why we chose not to just do $200 up front or $400 up front? Seems counterintuitive. What's that? Could be budget. This is where our social scientists were helpful in helping us understand the nature of the community. Number 1, traditional encashment methods. We would ask people to come to a specific location and line up on a certain day and to receive their cash. Number 1, the community said we don't want to be identified as either having a family member that died from Ebola or ourselves having survived Ebola because of the stigma. That was number 1. Number 2 was simply security issue. Okay? When you give somebody that amount of money, which represents half of their annual income in many cases, it causes what economists refer to as economic shock or income shock, meaning they're finding themselves with resources that they otherwise would not have had, not knowing how to spend it, and most importantly, the security issues that mobile money agents pose within specifically outlying areas outside of Monrovia. So that was really the design principles behind. We used the largest reaching cell phone service provider in Monrovia called Lone Star. This thing is doing phantom stuff for me. Lone Star was the number 1 provider, covered more than 60% of the people within the country. And what we did is we did SMS cash transfers, which is pretty ironic that we don't use such a system here in the United States, right? If you have a presidentially declared disaster in the U.S., FEMA doesn't send you your payment via SMS text. We receive very few federal programs via SMS text. But most people in the country had at least a SIM card. They may not have a cell phone. What was very common behavior statistically is people having their SIM card, and then if they needed to make a phone call, they'd go to their neighbor, and they'd borrow their neighbor's phone, or the person in their neighborhood that had a cell phone, and they'd put their SIM card in. Now, a couple of problems. In the United States, if I have my cell phone off, like I do now, and somebody texts me, hey, Jono, you have $100 waiting for you, go to Western Union. If I turn my phone on 2 days from now, I get that message. That doesn't happen in Liberia. Meaning that we're assuming that when we send an SMS text message out, that the person has their phone on, they have their SIM card plugged in, and that they receive the message. So extremely challenging, right? The telecommunications infrastructure has significant challenges, but we knew it was the best way to reach the most amount of people, partnering with Lone Star, what they call their mobile money services. Mobile money is a very common phenomenon in the developing world. In Haiti, our number 1 method to do outreach and social messaging and financial payments was through SMS cash transfer. So we started doing these cash payouts, and the idea was to enable the survivor or their family member to make their decision on their own with consultation of, obviously, community members on what the recovery looked like. Other organizations are very uncomfortable with cash transfers, cash in general. They want to give them a jerry can. They want to give them a mattress. They want to give them a tarpaulin, things that they would have otherwise lost because they were destroyed in their household. And one of the survivors that I met with in our Survivor Network group said to me, I'll never forget this phrase, please don't scratch me where I don't itch. And he repeated that. Don't scratch me where I don't itch. And this young man, early 20s, survived Ebola and became an advocate for trying to promote good humanitarian standards in what type of assistance we were providing. And in his case, the aid community assumed because he lost his house and all the contents within his house that he would need household goods. So this particular gentleman received 5 mattresses, one from each of the individual aid agencies who made assumptions around what the community would need and how they would need it. The other geeky economist side of this equation is that by doing so, international aid organizations typically avoid local procurement because it can be difficult. And as a result, it suppresses local markets. And one of President Sirleaf Johnson's key mantras was, we cannot shut down local markets because we will further harm livelihoods in the country. So you had all these aid organizations bringing in stuff into port and assuming that's what the people needed. And we made a calculated, deliberate decision. We had lots of colorful conversations with our donors to say, you have to trust that cash is best. It's the most efficient modality. It's the most humane modality. And most importantly, we don't want to cause more problems. Domestically, the analogy that we use is when we hand out bottled water in the U.S. post-disaster, outside of a Target or a Walmart that's open, we're harming local business. Oh, granted, those aren't local businesses. They're multinationals now. But you get the point. And the same thing happens within countries like Liberia, where the aid community assumes that by bringing in non-food items, or NFIs, we're doing the most good for the country. So these are just some of the statistics around how many families we were able to trace. It was extremely difficult because of the loss of identification and procedures to document who people were. But we're still doing economic security programming in Liberia to help restore livelihoods and to rebuild communities. A little bit about impact. This was one of my mandates, was to set up a monitoring and evaluation system to know that the cash was actually working, or to hypothesize whether or not it was. And a couple of the comments that really stood out to me: ICRC is like a god to me, came to her aid. This was a particular beneficiary that we served, and it's not to credit the ICRC. There were other organizations that were doing cash-based programming, and I would argue would have similar results. This was very typical. This was a lady whose husband left her because of the stigma. Her neighbor's children were left with her when they both died, and they had 6 children on their own. So here you have a woman with 8 children, 6 of whom are her own, and a terrible stigma attached to her having survived Ebola. Kind of other impact, we saw terrible issues with depression, and there we go. One of the number one uses for the cash was to restore micro businesses. So there was a lot of people selling dried fish in local markets, or that they would sell secondary goods. This individual wanted to use the $200 to start a coal, to buy coal so that she could actually cook things to sell in the local marketplace. In this particular case, this highlighted one of the number one concerns that we were working with the Carter Center, which was suicide and severe depression, obviously attached to loss of life. And ICRC made a great impact on my life based off of the resources that were there. And these were just samples of the measures that we were trying to use to signify that there was an impact using a cash-based intervention. Last but not least, I'll kind of open it up for questions after this. Part of my fascination with this mission is that I don't believe Ebola is going to be the only thing that I see in my lifetime. And certainly for my years of Red Cross experience, had not interfaced as closely with the medical community. But the interdisciplinary approach I thought was extremely healthy, and having medical professionals at the table with psychosocial professionals, with economists that were understanding the livelihood programming side. And one of the quotes I often cite when I'm working with Red Cross volunteers is that our mission is bigger than any one of our programs. Because a lot of times we get grant funding, we get very focused on one particular thing that we do programmatically. And the realities are that if you don't stop and step back from that program and ask yourself, what's the mission of the organization? And that was something that Creighton instilled in me as an undergraduate, is that we're not just focused on your work as a political scientist or as an economist. Step back, and evaluate what your values are, what your morals are, what your ethos are. And that's really what drives the work that we do. And the other salient point that was really interesting to me, I like to explore abandoned buildings, which may not be the safest thing to do, but this happened to be a very safe building, which was one of the first 5-star hotels in Africa that was built in the late 1960s. Unfortunately, was a refuge for many of the people that were seeking safety and security during the Civil War. Many people lost their lives there. And I climbed to the top, and I felt that this quote really symbolized what I saw in the humanitarian organizations that were on the ground, within the local Liberians, and with the spirit of the response that was there, which was we're all fireworks, rising, shining, scattering, and then finally fading. And it really hit home when I saw that. It was graffiti back in 2014 that really symbolized what has happened over the course of time within Liberia. And then last but not least, I think this was ironic. This was the day I left Liberia. So my friends gave me a hard time that, I leave and Ebola leaves. Unfortunately, that was not the case if you know the history. There were several surges in cases beyond what we saw. But a large part of the humanitarian response was enabled by the U.S. government's decision to actually fight Ebola at the source. And it's not a political statement, but I will say that I was extremely proud of my U.S. government for making a very tough decision and actually sending troops, health services, and other components of the U.S. government into the hot zone to make sure that we were addressing the root cause instead of what I call consequence management. Domestically, Red Cross was working with local public health, state public health, and HHS on some of the concerns that were here in the U.S. And I was a little bit disappointed that we didn't earlier seek a solution that would actually address the root cause of the problem, which is a lot more sustainable, impacts a lot more human lives, and values dignity in that way. So I'm going to pause there and really just open it up to any questions. Happy to dialogue or see if there's any comments that are out there. Yes?
I don't understand how the money is. So you have it on your SIM card. Then what?
So what would happen, individuals would get a text stating that they have mobile money waiting for them. They're waiting for them, and then they have to go to what's called a mobile money agent, similar to like a Western Union, and then they could present a code, an identification. You can understand why it's difficult if they don't have an identification, in order to have the agent give them the cash. It was private. Yes, sir.
I don't know, you might not know this, but what were the donor concerns about handing out cash?
So we're fortunate that for the Ebola response, we had lots of Western European, USAID government funders that weren't as concerned as they had been previously. Traditionally, outside of this response, it was that people would make the wrong decision and that they would do the wrong things with the cash. And we have such a large volume of literature with amazing data that suggests that it's no different with non-food items. Like if Janice is thirsty and I give her a bottle of water, that's great. But if she's not thirsty, what's she going to do with the bottle of water? She's going to sell it. So there's, I did a couple of monitoring and evaluation studies in Mexico, post-hurricanes, a couple of studies. And, U.S. government's famous for giving tarpaulins, tarps, post-hurricane. The percentage of people that sell those tarps is greater than 50% because they have more essential need. But there is a school of donors that very much devalues individual choice. I'm oversimplifying it a bit, but they don't trust that the cash is going to be used for good programming. There is a lot of work. There's a group called CALP, which is Cash Assistance Leadership Learning Portal, CALP. It's a 501c3 based out of the UK, their equivalent of a 501c3. And they're trying to promote the desire to move from non-food item distribution to cash distribution using data. And I think it's gotten better because we actually have data points that suggest that it's actually working. It's a lot more cost effective.
What happens to the other money? So if you have 1,000 people that take advantage and they come to Lone Star and get their money,
you've offered out to 4,100 or however you will. Where's that money in between? Or is it sitting at Lone Star waiting and then it comes back? Or that's a lot of money.
It's a lot of money.
Where is that money?
We call it cash suspense. So we get a drawdown. We get a drawdown report each month to show who's drawn down. People that haven't drawn down, we remessage. We also use social mobilizers. The people that are out in the neighborhoods, we actually trace the family. So people on mopeds, bikes, buses, trying to get out there and to say, I got to find Jono because Jono hasn't collected his cash payment. That's still not 100% effective. So that programming, as a program manager, we make decisions on how to reprogram it for other economic livelihoods. One of the redirects for some of that cash was in farm subsistence. Liberia is not well known for their ag business, and there's been a lot of work to try to develop more sustainable economic impact around agriculture. So we microseed funding to farmers that may have had Ebola or that their families have Ebola, teach them farm education, etc. And that is one of the most difficult parts of the cash programming is you look at the suspense of that cash and say, what do we have left?
Well, it's sitting there and
Exactly.
does it have an end? Like if I have money and I don't collect it in a year or something?
It does. We give people 1 year to collect. We trace for a year. Anything after that, we reprogram. Because part of our challenge as an NGO is there is no longer international armed conflict or armed conflict in Liberia. So our delegation was on the verge of closing a year and a half before Ebola. And so our permanent staff that were there were just a handful prior to the outbreak, and we resurged, rehired local staff to help augment. But our goal is to close that delegation, assuming that there is a permanent peace presence within the community.
Vis-a-vis Ebola and HIV, we have no cure for either one. Is that correct?
Correct.
So with Ebola, you may eliminate it from the blood, it's hidden in certain areas like the eye and the iris. What used to be called protected immune tissues, the brain was thought to be the blood-brain barrier. What are the prospects of detecting if there is still any Ebola, particularly when you can't measure it in the blood? What's going on in terms of permanently getting rid of it?
So I can't speak to the medical portion. I will speak to what we saw being the largest challenge going forward because of the way that the virus stays in the system. The focus groups that I led were mixed. I had male focus group, all female focus group, and then I had a blended focus group. The prevention that we were suggesting post-Ebola was to abstain from sexual intercourse for up to a year within the community. The social scientists that developed this guidance for us was extremely aware that was going to pose significant challenges, particularly in Liberia and West Africa. And the males that I spoke with, I gained much compassion and empathy towards because they felt that it was an assault to who they were as males. They felt that it was unreasonable to ask them to abstain. They felt that it degraded them as human beings. And it was a very difficult dialogue because we know that the virus can pass through sexual intercourse. So the medical staff that we had on the ground were very aware that this may be the end of the current strain of the Ebola virus, but that there's a likelihood that there's going to be flare-ups. All it takes is one patient going to the wrong place, touching lots of people, and it could spread again. But I believe that we've learned a lot as an international health community. Certainly the Red Cross, Red Crescent societies did in terms of what we should do next time this comes back in order to prevent it from spreading as prolifically as it did. But it does give me great worry because there are significant cultural barriers that I as a Westerner couldn't speak to. I learned a lot, I listened a lot, but it was impossible for me to say, Jono, you can no longer have sexual intercourse with your wife. I know that's what I should be saying, but there were men, grown men, young men, without families that were looking me in the eye and said, I no longer feel like a human being, based off of what you're asking me to do. The women kind of channel that focus group. The women felt unsafe. The women felt at danger because they knew that culturally to disregard their spouse and to deny them what could be a very dangerous practice, sexual intercourse, was very much against their cultural norms and standards. And that's where I felt that the international community of psychosocial professionals really could have been insurmountably valuable in trying to help understand the cultural barriers that, quite frankly, spread the virus to begin with. Janice?
Regarding spreading the virus, do you think that the impact was made of a permanent change in burial practice rituals? And how about the introduction of cremation to a society that isn't already have that?
So I'm an optimist. However, I don't believe so. I really don't. The infrastructure is not in place to systematize cremation as a cultural practice going forward, nor from a practitioner operator's perspective. You know, we have just an amazing system in the U.S., but even domestically, when I was in Newtown, Connecticut, and there were lots of dead children, the coroner couldn't keep up. The mortuary couldn't keep up. You take that and you transplant it to Liberia, where it's 80 times worse. And despite the funding that's going into expanding the capacity of the Ministry of Health, there are significant challenges that I believe are going to prevent that from becoming a cultural practice just from a systems operator perspective. Unless there is a surge of international aid organizations that help over the long run and fund them over the long run to help move the needle slowly.
What about touching the people with burial? And did that message go out, or was it just temporary?
Temporary. Even during my stay. So, you know, I'm a touchy-feely guy. I come from an NGO. I was told I had to fly through Geneva and fly out of Geneva for both health screening and psychosocial screening because they wanted to make sure I could, any delegate was going to be able to withstand what they were going to see. You know, and I was told, you know, there's a no-touch policy. You don't shake hands with your colleagues. Things that we're just used to doing. First day, I got in at 3 a.m. in Monrovia, get in the car at 7 a.m. to go meet with the chief physician. What do? Put my hand out. You know, it's you know, here I am, a Westerner, doing it. And one of the most disappointing facts of, I think, what we saw, nightclubs weren't closed in Monrovia, and people were dancing on the weekends. They would go, the NGO community in general, saw some, you know, just some disturbing trends in terms of how the NGOs amongst themselves were hugging in public. And those are things that take discipline and good leadership within the NGO community to enforce what we're trying to tell local communities is in their best interest. I was no less at risk than somebody else that I was telling not to touch or hug. But it was hard. I think that it's still today, with the survivor network, I mean, most of the survivors that we talked to contracted the virus because they were caring for their loved ones. One paramedic, most heart-wrenching story that I had was that the paramedic that went into the household because he felt like it was the right thing to do to extract the sick people, even though that he felt he was putting himself at risk. And 2 days later, he came up with high fever and checked himself into the Ebola treatment unit. You know, he didn't have PPE. He didn't know how to access PPE. That was just what he was trained to do.
Yeah, we talked about a lot of the institutions or agencies that went to Liberia that had preoccupation with the immediate medical need. And you also talked about some of the long-term needs that are present, specifically the psychosocial needs. So with those institutions in general and the Red Cross specifically, what do you see, what is being done to address those long-term needs and then also to build up institutions and infrastructure when you may have another outbreak? Sure, that's a great question. So post-natural disaster, we often see there are great opportunities to impact systematic changes socio-politically as well as economically. And the organizations that are listed here, I listed because they now have a permanent presence, semi-permanent presence in Liberia. My American Red Cross, who detailed me,
to ICRC said, we've got to do something to make sure that next time, whether it's Ebola or another thing, we're better off. We're leaving the community better off. So we significantly carved out a portion of funding to make sure we have a permanent, semi-permanent mission there. Same thing with the Danish. The Danish had been there for a decade plus, and a large part of their programming going forward is around communal health practices, building infrastructure within the public health system in partnership with the government of Monrovia, the Ministry of Health, to try to systematize those things. I will say from a skeptic's perspective, what I get alarmed with is the antics and grant restrictions that WHO places on organizations in building longer-term solutions. My colleagues that were there on the ground from the embassy, he was quite disappointed that he knew this was going to solve a very small portion of the problem. And unfortunately, until there is more meaningful discussion around long-range fixes, those are temporary interventions. It's solving today's crisis instead of looking forward, elevating your gaze, and trying to project what the next 5, 10 years are, especially with President Sirleaf Johnson has just over a year left in her administration. And there's a lot of worry around the infrastructure in Liberia, what happens less than a country away in the Ivory Coast. There's been bouts of violence. Thank goodness they didn't have a huge surge in Ebola, but all it takes is the right political environment to destroy some of the gains that were made under this particular outbreak public health emergency. So I do see signs of hope where some organizations are engaging more permanently, but I think it's scratching the tip of the iceberg.
Now the final program is starting.
Thank you all for coming. We're done with questions. Enjoy the rest of the conference.
I was wondering you were still there.
No. I didn't know if we were still running 10 minutes or... No, sorry.
I do think it would have been more extremely helpful. In